safety, patient experiences, and operations excellence here at the University of Iowa. Also joining us on our panel are our leadership friends at Mercy Hospital, starting with Shaun Williams, who is the president and CEO. He became president and CEO in May of 2018. He's a member of the Mercy One executive leadership team and was previously president and CEO of Mercy Medical Center in Clinton, Iowa. Shaun earned his BA here in economics from Loras College and his MA degree in healthcare administration from Des Moines University. He currently sits on the boards of the Iowa Hospital Association and locally with our peers at the Iowa City Area Development Group. Shaun is joined here today from Mercy Hospital by Dr. Stephen Shekel. He currently serves at Mercy Hospital as their Chief Medical Officer, Chief Quality Officer, and Vice President of Population Health and Outreach. Prior to this, he served as Medical Director of Mercy Emergency Care Unit for over 13 years. Dr. Shekel's areas of responsibility include medical staff affairs, Population Health Service Organization, the ECU, and as Medical Director for Mercy On Call. He is a board certified in emergency medicine, graduated from the University of Iowa College of Medicine, and completed his residency in emergency management at USCF Fresno. Also joining us today, we're pleased to welcome Judith Johnson Makokota, who's the director and was appointed director of the Iowa City VA Healthcare System in February of 2015. As director, Ms. Johnson Makokota is responsible for all aspects of VA healthcare delivery within the Iowa City VA Healthcare System catchment area. Ms. Johnson Makokota holds a bachelor's degree in nursing from Coe College in Cedar Rapids, Iowa, and a master's degree in nursing administration informatics from the University of Iowa. She has more than 15 years of extensive nurse management experience in private sector healthcare settings. Rounding out our panel today are Dave Koch, the Director of Johnson County Public Health, and Dave Wilson, who is the Director of Johnson County Homeland Security and Emergency Management. Dave Koch began his career in public health in 1991 as an environmental health specialist for Lynn County Public Health. He then spent the next 21 years in various aspects of public health before becoming Johnson County's Community Health Manager in 2012. And in 2017, he became the Director for Johnson County Public Health. Dave Wilson has served our community for the past 30 years. He's worked for Coralville Fire Area Ambulance, Johnson County Ambulance, Iowa Disaster Medical Assistance Team, and now at Johnson County Homeland Security and Emergency Management, where he has served as the director since 2007. In his time here, he has seen us through the 2008 flood, public health outbreaks such as H1N1, as well as the subsequent floods in 2013, 14, and 18. Dave has worked diligently to bring a wide array of training and exercise opportunities for our first responders, partners, and elected officials. How to ask questions for today's panel. You can see here on the screen, click and open the QA box, submit your question, and wait for either a reply or notification that it will be answered live. This webinar is We Are In This Together shared communication plan. It's part of a larger effort between our four organizations to keep the community informed as to the state of our community, whether it be through government, social services, healthcare, or other sectors. This particular webinar is produced every week on Wednesdays. Next week, Iowa City Downtown District Nancy Bird will moderate what's happening in our arts and culture community. Like that one and the one today, there have been a few other webinars which you can find on the website at iowacitytogether.com. The Iowa City Business Partnership will also host a second webinar next week on cybersecurity. This pandemic has forced small businesses to get creative with how to stay productive while also ensuring the safety of employees, families, and communities. Now that so many organizations, including ours and many others, have moved to remote working, it's an excellent time to take a better understanding as to the virtual and VPN risks associated with your business. ProCircular CEO Aaron Warner has pulled together a webinar based on experiences of these clients that will help you navigate this new reality. You can learn more again about all of these webinars on the website at icareatogether.com. Just a point of note for today's webinar, we will do our best to get all the questions answered during the allotted time. We will go through 3 o'clock. For those we are unable to get to the questions, we will do all we can to get them answered and then post answers to those questions on our website in the coming week. So with that, I'll open it up to our panel here. And again, I want to thank all of you for joining us. To start, I've asked each of the 4 different groups, the 3 hospitals, and then Johnson County, to start with just a little 5 to 10 minute update as to what's happening in their particular institution and the planning that's going forward for possible surge or any other activities. We'll start today with Dr. Brennan at the University of Iowa Hospitals and Clinics. Doctor?
Thanks, Josh. Really happy to be here and be able to communicate with you and the community today. As Iowa's Academic Medical Center, I feel like we're uniquely ready to take care of these patients and to continue to take care of the patients that we have that don't have COVID-19. We are pursuing research trials with regard to treatments, and our researchers are looking into vaccines as well. I also want to make a note that I'm really happy to be a part of the community. We have had such amazing outpouring from the community trying to help our healthcare workers, in support of healthcare workers throughout the city and the region. And I can tell you that in times like this, when people are very stressed and anxious and even fearful, that support is really priceless. Just to tell you a little bit about what's going on with us, we have taken really a 3-pronged approach to the COVID-19 outbreak. First thing we did in conjunction with our University of Iowa Physicians Group was to create a mechanism for patients to get easy access and easy care, and then subsequently easy testing. So we created a video visit. So we want all of those patients to actually see us virtually before they come in. That does 2 things. It actually facilitates more rapid clinical care, and it also helps to contain a potential virus. If the person is infected, for us to be prepared when they come is really important. After that video visit, the patient may have the opportunity to come to our respiratory illness clinic. We've called it many things. Initially called it our ILI or influenza-like illness clinic, but now we're referring to it as our respiratory clinic. That's a place where they can either get treatment, get evaluation for other potential infections, or get tested. So that first prong is really easy access and early treatment of the patients. The second thing that we've done that is somewhat novel is that we have developed a home treatment team. So for every patient who is diagnosed through our system, we actually deliver them a blood pressure cuff and a pulse oximeter so that they can monitor themselves at home. And they get a nurse call visit. So the nurse calls them, asks them how they're doing, reinforces the need to be quarantined, and talks about what sort of things would prompt them to need more care. Things that would make them perhaps need to become an inpatient or come to our emergency room. Within that kit is a list of those things and then how to contact us if they have any of those. Then for those high-risk patients, we have a daily visit, kind of like a virtual hospital. So our providers, our physicians or advanced practice providers would call the patient who is in that high-risk group. So everyone over 60, we've elected to put our pregnant patients into that group. And then anyone who has been discharged from our hospital, who is COVID-19 positive and then discharged from our hospital, would go into that group, and they get a daily visit. With those daily visits, we've learned a lot, and I'll tell you a little bit about that in a minute. We did this because we wanted to make sure that, number one, the patients were getting support and coaching on how to take care of themselves and how to keep themselves out of the hospital. The second was we wanted to make sure if they were coming into the hospital that we would be prepared to meet them. Our staff and faculty need to have appropriate PPE on when they're meeting those patients, either in the emergency room or any clinic, and that forewarning is really important. The last part of the 3-pronged approach is that treatment in the hospital. So we deal with complex medical patients very commonly, and the patients tend to get respiratory problems, so breathing trouble and lung deterioration, and they also tend to get heart disease. They can also go into shock, and those are things that we're used to taking care of. So with our advanced modes of ventilation, positioning of ventilators using something called prone ventilation, which has been shown not only here but internationally to be helpful to patients. That's where we put them on their stomach instead of on their back while we ventilate them. With those things, we've been successful in being able to treat the patients. So let me tell you a little bit about the outcomes that we've seen. To date, we've had almost 6,500 patients go through our influenza clinic, and we've had, our video clinic, and we've had almost 2,000 patients go through the influenza illness clinic. The home treatment team has followed 71 patients to date on a daily basis, and they've ultimately recovered from the disease. They're presently following another 91 patients, so getting that daily visit on 91 patients. And I'm really pleased to tell you that of those 162 patients, we've only had 4 patients require hospitalization out of that group. So if you look at the national and international statistics, it's expected that about 20% of patients would be hospitalized, and 4 patients is far less than 20%. So we're really excited about this. And what we've learned from that group is that the most likely cause of initial hospitalization is actually dehydration. And when you have an illness like this, you have fever, which causes loss of body fluids, and they feel terrible, so they don't want to eat or drink. But what we've also found in these patients is that they have a high likelihood of losing their sense of smell and of developing a bad taste in their mouth. So many of our patients have described it like they're eating or drinking dirt. And obviously none of us wants to eat or drink dirt. And so therefore they don't hydrate very well. And so what this home treatment team or virtual hospital has been able to do is to really encourage and coach those patients that they must drink. And therefore we've been able to keep them out of the hospital. In the inpatient setting, I talked a little bit about the prone ventilation, which is one mechanism that we've been successfully able to use to get some of these patients off the ventilator, which is really exciting. We also are participating in research studies. One is for a medication called remdesivir, which is a medicine that actually fights the virus itself. We are participating in the recently started study on whether remdesivir is a good treatment for this virus. And we are also, have also been able to use it compassionately through the FDA. The second bit of research that we're participating in from the inpatient setting is beginning to collect plasma from patients who have recovered. So I told you earlier that we've had 71 of our patients get the virus and actually recover in our home treatment team group. And so we can collect plasma from those patients. That plasma has antibodies to the virus. We can then give those antibodies in that plasma to patients that are struggling with the virus presently. So another mechanism of potential treatment. And then the last thing I just want to make note of is multiple groups are working on vaccines, and we're not any different. And recently one of our groups had published on a mouse model looking at a MERS-like vaccine that could potentially be the foundation for a vaccine for COVID-19.
That is great. Thank you, Dr. Brennan. I know we'll have a couple questions for you here after we go through our updates, so thank you for that. Next, we'll move on to Shaun and Dr. Shekel over at Mercy Hospital to give an update of what they're seeing there.
You bet. We saw some of our first patients with COVID-19 about a month ago, and we instantly set up an incident command that allowed us to assess the situation, determine what we needed for supplies, for staffing, for appropriate procedures, et cetera, and have kept that in place daily. And what that's done is allowed us to really think about in advance as to what we might see for patients, what types of patients we're going to see, and what resources we need to make sure that we have ready to deploy. So out of that has come a lot of work to make sure that we are prepared to meet the need in the community. Several things that are of note. One is we converted our largest inpatient unit to a negative pressure unit, which allows us to house COVID-19 patients and other patients, if need be, with respiratory illness in a safe way so that they're not infecting other patients or staff members. So that was a major initiative that we really stood up in a very short period of time. We did open up a respiratory clinic, freestanding tent, if you will, in Corville that allows folks that need to be treated and able to be tested and treated in a way that isolated them from the rest other patients and do so from a staff perspective in a way that allows us to conserve PPE or protective personal equipment so that they can not only do the testing but provide any care that they may need. We also have drive-through testing at that location as well. We also stood up telemedicine solutions, so individuals can see their provider remotely, and frankly, that's been gone over very well. We're seeing almost, not quite, but almost 300 patients per day via that modality, and I think that helps in a number of ways. One is it can help us screen patients that may need to be seen in person, but it also helps alleviate some of the concern and the anxiety that a lot of these patients have. So that's been very successful. On the emergency side, obviously when individuals present in our emergency department, and Steve can reference this in more depth, we're very careful on how we screen them, how we determine what risk there may be, and how we appropriately treat them and get them in the right setting. Along with that, the testing has been a question and a concern, I think, for most organizations, is how much testing can we do? What are the appropriate opportunities to do testing, and then what's the impact? And right now, as we all prepare for the predicted surge, and I'll talk in a moment about some of the modeling around that, but as we prepare for this predicted surge, one of the obvious areas of focus for all organizations and healthcare providers is to not have unnecessary testing. So if individuals don't meet criteria or don't need to be tested, the reason is we want to make sure that we are preserving and conserving protective equipment so that when and if that surge hits, we are as prepared as we can be. And we also make sure that what we do is very much being directed and in line with our partners in emergency management in the community, but also IDPH and the CDC to make sure that we're following all of their guidelines for testing. And one of the things I'll maybe ask Dr. Shekel to address in his comments is some of the in-house testing options that will soon be coming online that will allow us to, in a much quicker fashion, test individuals and determine, what is the appropriate placement. I think my last overall message that I would put out there is the community has been tremendous from an emergency management perspective, from a medical community perspective, and the community at large. Everyone has pulled together, shared information, shared best practices. We've had an outpouring of donations of equipment to folks offering to help make, masks, et cetera. Just a tremendous support. And I think it certainly is edifying for all of us to know that as a community, we really are in it together. We really are there and supportive of one another. We share information with our partners, not only at the university, but at St. Luke's and Mercy and Cedar Rapids. We have routine communications between our chief medical officers and our CEOs and others to make sure that we know where everyone's at, we know what everyone's doing, and again, so when and if we hit that predicted surge, that we're able to be there for one another and support one another. That feels good, and I think should give the community a sense of confidence that we as a community, from a healthcare perspective, are very much approaching this in a united front. I think the last message would be a sense of calm and assuredness that this is a crisis, no doubt, but it's not radically different than previous crises. And we've had similar, maybe not all at once, like this particular pandemic, but we've had similar situations like this in the past within the healthcare community that we've prepared for. And I think it's really important that individuals remain calm, have a sense of confidence in their providers, a sense of confidence that if they need further care, they will receive it. But a reminder that this is, for most individuals, this is very treatable illness. It's something that certainly has to be concerned about if they're of a certain age cohort. or other underlying conditions, but it's important that for most individuals, this is something that is very manageable and that most people will not need to be admitted, will not need to be seen in an emergency department, and that for those that are of vulnerable health, obviously they're going to be a major focus and they'll continue to be going forward. But as the country and the state prepares for, hopefully in a few weeks, maybe going into phase 2, hopefully looking at what's next in terms of how we manage this pandemic. I think that message is an important one, that people know and understand there is absolutely going to be a safe and appropriate way for us to start to reengage when that time is right and it's deemed appropriate by the appropriate professionals, and that we can do so in a way that's going to be safe and folks can be confident in.
All right, thank you, Shaun. And I know we do have a couple questions for you, Dr. Shekel, that we'll ask, but did you have anything you wanted to add to Shaun's comments at this point for an update?
Yes, yeah, thank you. Just to follow up on Shaun's comments, our approach to this is recognize it as a crisis or a very, very significant event, but at the same time, stay in control and be as proactive as we can in our planning process and be prepared for whatever might come our way. And just, people may know this, but the first cases diagnosed in the state were actually at Mercy Hospital here in Iowa City about a month ago, but just a little bit more than a month ago. And the next day, that was actually on a weekend, the next day we set up our incident command, and we've been meeting on a daily basis ever since that. And from the very beginning, we tried to take stock of our resources, find out exactly how prepared we were, and based on that, plan ahead so that we could face the surge that everybody talks about, and people, unfortunately, in places like New York and Louisiana, Washington, and California have experienced. And a lot has happened since then. Shaun talked about most of the things. We do have basically a COVID unit that's completely negative flow, ready for up to 30 or more patients. Fortunately, we have not had as many COVID patients as inpatients as we initially expected or anticipated, and that's great. I think the efforts that have been done around this whole community, including what Dr. Brennan has described, have been fantastic about trying to keep patients who do not need hospitalization but may be COVID positive at home, but closely follow them. We have been doing that with the help of Mercy on Call and also our health coaches, not just to patients that don't require hospitalization, but also, as Dr. Brennan referred to, patients who are discharged from the hospital who have been diagnosed with COVID. We also follow them on a daily basis to make sure that their progress, they're not having relapses. The other thing, in addition to the negative flow COVID unit, we have all of our ICU beds in a negative flow status. Taking stock, currently we usually have 6 to 8 ICU beds available, but we've ramped up to having the ability to have 18 ICU beds, so we're trying to prepare for the worst case scenario. And as part of that process, we've identified all staff members in the hospital who have certain privileges that they may not use usually, such as ventilator management. And those staff members that have the privilege but haven't utilized that privilege for some time, we're providing refresher courses for these individuals. So in the event that it's going to be all hands on deck, we're ready for that. So we have it set up so we have different tiers where we call different people in and to assist in the care of these patients. But prior to that, we want to make sure they're ready to do that. So we've been planning. Another very big thing that has helped us has been communicating with the area hospitals, and certainly Dr. Brennan from UIHC, but also our colleagues from Mercy Cedar Rapids, St. Luke's in Cedar Rapids, and also surrounding hospitals like Washington County and Jefferson County Hospital. And again, following that motto of we're all in this together, we want to be there not only to take care of our patients, but to support our colleagues around this entire area so that we can be flexible and make sure that we can do the best for the community at large and let nobody hang out there alone and be in trouble without providing them all the assistance we can.
All right, thank you, Doctor. Appreciate that update. Judith is the director of the VA, and Judith, I'm sorry I misspoke your name on the front end. I'm a destination marketing guy, so every time I see your last name, I think Makokota because the Makokota caves are so cool. So it's Judith Johnson Makota. So thank you for joining us, and we'd really appreciate an update that you might have for really the VA, who services one of our most absolutely important populations, and those being our veterans. And anything that you're seeing or any differences that might be a little different than what's happening at Mercy and University Hospitals and Clinics.
No, certainly, I do want to share, and hey, thanks, Josh, for setting this up and inviting us. I know that many people in the community probably drive past this hospital on Highway 6 and just see a red brick building. And if you're not a veteran, you may not know what we do here, but I just want to share with you a little bit of information about what we are doing here. So our catchment area is fairly large in terms of our veteran population. So we have 33 counties in eastern Iowa. We have 17 in western Illinois and 1 county down in northern Missouri. And so we treat almost 55,000 veterans, and we have almost 1,900 employees. So there's a main hospital here in Iowa City, and then we have 10 community-based outpatient clinics, of which the core services are primary care and mental health, but we also have physical therapy, audiology, and some other services as well. So, but we're also part of a bigger national system. So we're part of the VA Midwest Healthcare Network. So that's comprised of 10 states and 8 healthcare systems. And so really we've been working with our other VA systems and national office over the last several weeks to coordinate the VA response to this virus. And so I want to tell you that we stood up our incident command about 6 weeks ago. And so to minimize the risk, within a week, we secured our entrances to visitors and employees and started active screening at all our sites of care. And so we know they may lengthen the entry to our facilities, but we've advised veterans to plan accordingly if they do come or do have the need to come on site for a visit or any type of encounter. We have, when we have found veterans that are positive for screening, we have an assessment center that has an external door to the building here. And so they're escorted and evaluated in the assessment center, so they have no contact with the interior of the hospital at all. And so that's been a great assessment center for us in terms of being able to evaluate veterans. We also have initiated curbside assessment screening for veterans so they can drive right up to our entrance here and assess and be screened. We have a local call center for veterans so that they can call our main hospital number and press 5, and then they have the ability to have direct contact with either clinical or administrative staff to address their questions or concerns. Our entire operational footprint really has been reduced by over 80%. And so our face-to-face clinics have been reduced, and we have converted to telehealth and telephone visits, as I know many other healthcare systems have done as well. Our elective surgeries have either been canceled or rescheduled to a later time, but we need to let people know that we're still open for business. We still have outpatient dialysis. We still have some specialty services here available, chemotherapy. So we need to know that we have a lot of teams on site. We have a very robust mental health team, and so they're able to assist as well. In terms of the COVID testing, I want to mention that we have an agreement with University of Iowa in which we have VA staff working in the University of Iowa lab to assist with the testing process. And so we're very fortunate to have their support and collaboration. To date, the Iowa City VA has had 3 outpatient and 1 inpatient who have tested positive for COVID-19. Similar to what other sites have done in terms of surge planning, we have used predictive analytics and modeling as well. And so we have now, similar to Mercy, we have an entire floor that's negative pressure, 29 beds, fully staffed and operational and just ready to prepare to assist those patients. We are also adding additional beds. We're working on that actively now. We're also repurposing our clinical staff to either work in the COVID units or assist in some other areas, as well as our non-clinical staff, giving them basic training to help them support our clinical operations. I'm really proud that we have an extensive labor pool and everyone's prepared and ready to meet the needs of our veterans and the community. As noted, we have 7 other healthcare systems within our network, and we can also draw upon those staff as well if needed. So currently we don't have any inpatients at the Iowa City VA, but we know that could change quickly. So we stand ready and prepared. So thank you.
Thank you, Judith. Just as a reminder, we will open it up to some questions. There have been several that have already been submitted when folks were finding out who was going to be on this week's panel, and so I'm prepared to ask those after our last two brief updates by our Johnson County leaders, Dave Coach and Dave Wilson. So, Dave Coach, we'll start with you, and any updates you can give as far as Johnson County Public Health.
Yeah, thank you again, Josh. Just like the other panelists, I appreciate the opportunity to share what we're doing here locally and just reiterate the tremendous partnership that we have both with the hospitals and emergency management, the support that we get from the Board of Supervisors and Board of Health as well. We really had two main goals from the public health standpoint. The first goal being really accurate, timely dissemination of information to the community. And secondly was to continually investigate, do surveillance work on the positive cases. So we work very closely with Iowa Department of Public Health. We're in contact and continue to be in contact with them on daily calls. You know, we continue to monitor those individuals that are under surveillance, doing the contact tracing. So as the cases continue to rise here in Johnson County, we've done some additional training for staff internally. We have 2 full-time disease prevention specialists that do this work year-round. We have over 50 communicable diseases in public health that we track and do surveillance work. This is just another one that was added to the list. But this is work that they do every day, all year long, but we did add several other staff to help them in that work. The other point then is the communications, and really from the beginning, we've worked very closely with emergency management, with the Board of Supervisors. We've set up a public information team at Johnson County Public Health. They are putting together daily press releases with information. We've got 2 press conferences weekly that healthcare representatives, school districts, other organizations also are able to share information. And really setting up a website specifically for Johnson County with some Johnson County data, and that can be gone to and found from our homepage at Johnson County Public Health. Really, I just want to emphasize, you know, some of that messaging that we've been talking about that we hear all along, but there's certainly the businesses have done a tremendous job of providing opportunities for their employees to work from home. We've been encouraging businesses to do that, encouraging businesses to put in place those leave policies just to provide social distancing. It's so important what we hear all the time about keeping our distance from others, washing our hands, all those things that we've all been talking about. And I want to remind everybody too, from the novelty of this virus, as we've heard, there's constantly new guidance coming out from Iowa Department of Public Health. So perhaps what we said last week is not necessarily exactly what we're saying this week. And sometimes I think it's hard for the general public to understand how that messaging may change. We've been trying to be upfront with that as new information evolves, and you've heard the panelists talking about a lot of the research going on so that we can learn more and more about this every day. That messaging may change, but again, from a public health standpoint, we train for this just like the healthcare providers that you've heard. You know, we do scenarios on preparedness, whether it's for a flood or for any type of natural disaster. We've been through this, as mentioned before, in 2009 with H1N1. What's unique about this versus in 2009 with H1N1 is we do not have a vaccine to be able to provide the community. So really in 2009, we also were setting up points of dispensing locations throughout the community. We don't have that activity going on right now, obviously, but hopefully in the near future, if there are vaccines really provided to us, that would be another function of public health that we would be working with community partners to set up some points of dispensing to be able to distribute the vaccinations to help prevent the continued spread of this. So we're we're really grateful for everybody in the community that is heeding all of our messaging, trying to slow this spread and flatten the curve a little bit. So we appreciate, again, this opportunity to share more details.
All right, thank you, Dave. And for our last update, before we open it up to questions, again, if you have one, please put it under the Q&A feature within this webinar, and we'll do our best to get to it, recognizing that we've had a number already submitted and have those queued up to be asked. Dave, as I introduce you, Dave Wilson, and ask for an update, I do want to just ask you one of the questions that I was going to ask when we had Q&A, just because I know you have a standing EOC call at 3, and I don't know how quickly we'll loop back to you, but when you give your update here, if you'd provide any sort of comment, one of the questions that came in pretty early and often was, what further ground would you believe a shelter-in-place order cover that's not already mandated through some of the governor's orders, and just kind of address that question that's been asked repeatedly?
Sure. So first of all, I provide the update and I'll loop back to that. Thanks everybody for having us on the call. I think it's really important opportunity for us to be able to share with the community, business community, and the community in general what's going on, because unfortunately they don't get the benefit of being on those 3 o'clock situation reports like everybody on this call does. This is really a partnership. It's no different than any other disaster that we have. All disasters involve a medical component, and this one just the medical component is the major component. So our collaboration has been strong, as it's always been ever since I've been here in 2007 as the emergency management director. The hospitals do a Herculean event and are often, not recognized for the work they do on a day-to-day basis, and that goes as well for our first responders, our emergency medical services. Those people are there for the community day in, day out, and it's times like this when you really notice and rely on the healthcare community to step up to the plate, and people rely on them. And I think this is just a glowing example of the exceptional healthcare community we have in Johnson County and that collaboration and partnership that we have. Unfortunately, I've worked disasters throughout the United States and in Haiti for the earthquake, and that is not the same case everywhere, I can assure you. So people should be very proud of all 3 of the hospitals and the healthcare community and just the collaboration that goes on in general. We've been working on this over a month now, since Sunday night, the 8th of March. Seems hard to believe that I'm saying that. And it has been a coordinated and collaborated effort, and oftentimes we are faced with unique challenges that no one expected, and unique opportunities to partner with new people, and that has continued to be the theme, whether it's partnering with Think Iowa City on hotel rooms, or United Way on Quilters Association making reusable masks that can be laundered. You name it, it's a different challenge every day, and the community has stepped up to that every time they've been asked, from donations management to you name it. I could go on and on. For us, the challenge really becomes an information thing, managing expectations on what's going on with the supply chain and PPE, personal protective equipment availability. Obviously, we have to triage that. It has to go to the healthcare facilities, the long-term care facilities that have the most vulnerable people. Our strategy and our tactic has been to try and keep the disease out of the long-term care facilities as much as possible. We've been more successful than many counties in doing that. We have a long-term care center collaboration call that goes on at 10 a.m. every day, and we touch base with all those LTCs here in the county. And they're an important partner in monitoring what's going on in those centers from a risk management standpoint, and to try and keep case counts down, and when there are people that are diagnosed, keeping them isolated or getting them appropriate medical care when needed. So the coordination and collaboration has been outstanding. Partnerships have been outstanding. The challenges we face are not unique to Johnson County. Those supply chain and logistical issues are global, and those shortages, trying to move from a just-in-time, usually too late delivery model, where manufacturers don't keep warehouses full of equipment on hand, and a lot of things are made in foreign countries, swabs, et cetera. Those have been challenges that are not unique to Johnson County, and I think we've successfully navigated those very well. Looping back to the question that seems to be coming up nearly every day is what would a shelter-in-place order look like? I don't think anyone really knows for sure. So I'm supportive of what the governor has done, which was a stair-step approach to kind of taking away different opportunities for people to congregate while not impacting negatively the supply chain or key resources and critical infrastructure. There was an interesting analogy drawn between the state of Minnesota, and I think it was about 78% of the folks in Minnesota were basically exempt from a shelter-in-place order because they fell into one of the various Department of Homeland Security categories of essential and key resources and workers. The Google thing that was sent out the other day by Sam at Public Health, I thought was very telling. It talked about usage from people that have their location enabled on their phones, and it showed that in March, the majority of those folks were not congregating at places they normally would, whether it was businesses or parks, et cetera. There was substantial decreases in that. Obviously, we want people to stay at home and try and decrease the spread of this novel influenza, COVID-19, and anything we can do from a mitigation standpoint to reduce the spread and flatten the curve and keep our healthcare facilities from becoming overloaded is very helpful. But I don't know, and I don't think anyone can tell you with a straight face, honestly, how much more impact that would have. I can tell you from a political standpoint, it'd probably take a lot of pressure off myself, Dave Coach, and a lot of other folks if they would utter those words, because we wouldn't have to address it anymore. But I don't know, I'm not convinced personally, and as the emergency manager, that it would make much of a difference. And the reason I say that is most of those places that people have the opportunity to congregate have already been removed. You know, they're not going to pools, they're not going to fitness facilities, they're not going to casinos. You're not going to close grocery stores. That's not going to happen. They can still go to those. They can still go to the Lowe's, Menards of the world. So those aren't going to close. The mall's basically a ghost town, and to my understanding has been basically closed. So I don't know that by doing that, other than make someone feel like they've checked a box, I don't know what real impact that would have. It would take a lot of pressure off myself and Dave Coach, but I don't know what that impact would be that would make a real difference. And at the end of the day, it's a policy level decision. It's not something that Dave Coach or myself decide. We're asked our opinion on things, and we give our opinions, and ultimately it's an elected official policy decision. Right now, I can tell you the attorneys do not believe that power exists with either the county or the municipalities, that power is retained by the governor. And the governor has provided no indication that I've seen that she intends to issue such an order. So I guess that's all I really have to say about that. And I'll probably get in trouble for saying it, but.
Well, I appreciate it, Dave. It has been asked a lot, and I know of you and Dave probably more than anybody else, but of the rest of us that are somehow connected in some capacity. So thanks for that. And I do know you'll probably have to check out a little bit early. So thanks for that. Thanks for that update. We do have several questions. I want to get into them and get through as many as we can. So I appreciate the panel trying to be as concise, even though some of them might be a little bit technical. So Dr. Brennan, I wanted to start with you here. One of the first questions that came in was, could you explain some of the different testing measures that are being reported on throughout the media, such as PCR, serological testing, and what are the latest updates related to any in-home testing, as well as some of the things you already touched on related to possible vaccine development and drugs that are being reviewed for, to somehow mitigate the virus?
Yeah, so from a testing standpoint, right now the tests that are done in laboratory are two different kinds. The first is a PCR or polymerase chain reaction test that actually looks at whether the virus is in the nasal and oropharyngeal cavities. They take a swab, just like we do for influenza, and then run the test in the lab, looking for the virus itself. The second, and that's the most common, far most common test that you'll see being reported. The second option is to do a serological test. And what that does is it's a blood test that looks for antibodies to the virus. So when you're infected with an infectious agent, most of us, gratefully, will produce antibodies to fight the infection. And that serologic test looks for those antibodies to show that the patient has been infected and actually is making antibodies. I don't have a whole lot of data regarding the home tests. I basically can tell you what you could find basically online. You still have to have a doctor's order for it. They're sent to your home. At this point, the time is, it takes time to get the test to you, and it takes time to get the result because you have to send the test back to the lab. And so I personally would really favor doing it within one of the hospitals that we talked about, or clinics that are on the line here. The last thing you talked about is vaccine development and other treatments. So lots of different individuals are fortunately racing to find us a vaccine. If we could have a successful vaccine, that would be such a blessing. And so many academic centers, many private and commercial companies are working on it. So hopefully that will come quickly. And then the last is, what are different options? So the standard treatment for this virus is supportive. And that means giving fluids, treating medical problems, giving oxygen, treating the lung problems and heart problems that happen to the patients. There is not now an FDA approved treatment. I spoke a little bit about the remdesivir, which is an antiviral, meaning it attacks the virus itself. We don't know if it's effective on this virus, but that's what the trial is looking at. Convalescent plasma is another option. That's looking at giving the plasma from someone who's recovered, who has those antibodies, to someone who's fighting the disease right now. Hydroxychloroquine is another medication that is being tested, and it's in the news every day. It seems that people are very favorable to it or really unfavorable to it. So we'll just have to see what the studies show. So unfortunately, we don't have good treatment directed at the virus right now, but hopefully as the days go on, we'll have more information.
Thank you for that. Thank you for that. Dr. Shekel, sorry for that, I muted myself. What might the next 2 months or 6 months or year look like for this community in the country in response to this virus? We've heard, and read in various sources that there's possibility of another fall round 2 cycle and peak. What are your thoughts on that? And as it relates to obviously the local economy might, we're looking to what we can expect here in the coming months in the fall.
Yeah, that's an extremely tough question that everybody's trying to postulate on, but nobody really has the answer for. And so I'm going to give you my thoughts about that. I just want to mention, so I can slip this in it, I didn't really mention the thanks for the support that Johnson County Department of Health and Emergency Response have given our hospitals. They've really been there the whole time and have been a huge help for us in keeping track of the resources we have available and actually making resources available to us and helping educate the community. So thank you.
Absolutely.
About what's going to happen. Certainly there's talk of the second wave, and in my opinion, it's all about flattening the curve, as people keep talking about. What's really going to hurt us if we do have a surge in similar places like in New York, where all of the facilities and healthcare facilities are totally overloaded, not to mention the healthcare providers are either getting ill or they just don't have the number of providers to take care of these patients. That's what everybody's trying to avoid. What that may mean is that the curve is flattened, but it takes a little bit longer for the curve to really diminish to the point where people feel like we're past the worst part of this. I think the main concern about the curve or about the second wave is that if the restrictions like social distancing and people taking the proper precautions, if that is loosened up too soon, people who may be carrying the virus but are asymptomatic get out into the public and start spreading it again. And then people who are more susceptible or who have those comorbid conditions, other health conditions, get sick, and we might see another spiking of the curve or another surge. And so that's what everybody's worried about. So it's all about being very judicious and thoughtful about our planning. When we start feeling like the worst is past, we have to make sure that we don't go immediately back to the normal way of doing things and invite a second round of this. Various predictions about when we're going to see this finally tapering off. I think the April 30th marker is probably too optimistic. I've heard people saying that by June that we hope to see significant improvement in the conditions, but I think we're just going to have to wait and see. And the main thing is people continuing to practice very safe behaviors, such as the social distancing, and actually wearing a mask or cloth mask, and I want to stress cloth mask in public, to prevent the spread from an individual who might be carrying the virus, but being asymptomatic, prevent that person from spreading it to other people. And the CDC has recently come out with that recommendation. I think it's a very good one. So in other words, time will tell, but we can still all do our part to try to get this thing behind us as soon as possible.
Yeah, your point on the mask was another question I was going to ask of you and Dr. Brennan. You know, there's a lot of discussion and questioning of the use of those in the CDC's recent recommendations. Can you clarify the advice on mask and include suggestions for maybe possible best materials to use for homemade masks? Either of you?
Yeah, and I'll just jump in and let Terry follow. There are different levels of protection with the masks. N95 is considered to be really the premium protection, and that's reserved for healthcare workers who are in an environment where they are at most risk. The surgical or procedure masks provide the next level of protection down, which we have specific criteria for using those. And those really should be reserved for healthcare workers or in certain situations when people are particularly at risk. The cloth masks are mainly utilized to protect people who are wearing them from spreading it to other people, to stop that droplet spread from the aerosol that comes out just in normal talking. So it's been rated, if you consider the N95 at 95% protection, the surgical mask is considered about 90%, and the cloth mask up to 70%. But again, it's just designed to protect other people from the person wearing it, who may be asymptomatic but carrying the virus. And I think everybody should wear them when they're out in public and certainly within 6 feet of people. And
Yeah,
Terry, I don't know if you have anything to add.
Yeah, that was the only other thing. The only other thing I was going to add was that anytime you do risk mitigation, it's usually more than one thing. And so, as Steve said, the mask really is for source control, meaning I'm the source, I wear the mask, then the droplets don't get out to other people. But the other things that we've talked about today are so important. Social distancing, making sure that we isolate and stay at home as much as we can. If you have to go out into the community to go to the grocery store, or you're an essential worker and have to go to work, keep that social distance, and then wash your hands, and don't touch it.
Yeah, all the things that the public health department has told us and CDC has told us. So all those things.
Thank you, Judith. You know, from all we have read and heard, you know, COVID-19 is most challenging to our older generation, largely the demo of the veterans you serve. Are there concerns about your capacity and or are plans in place for a possible surge and partnerships with our partner hospitals here in our community?
Certainly, you know, we have a very diverse patient population. Actually, you know, while the average age of our patients is over 50, we have seen our fastest growing demographics have been in the areas of female veterans and veterans in the age group of 33 to 45 years of age. So we have certainly changed some of our care models related to that, and we'll certainly address those as they arise. You know, in terms of supplies and resources, we do have the supplies and resources that we need. You know, our logistics and emergency response teams have just done a fantastic job of leveraging VA and vendors in terms of acquiring resources. So we feel like we're prepared for the expected surge in patients, yes.
Thank you for that. Dave, Coach, a lot of questions about outdoor recreational opportunities such as biking and hiking. I know you and I had a conversation last week. There was some folks in town that wanted to know whether or not it was possible from the arts community to set up a fundraiser and go back to the 50s and do a drive-in movie theater and everybody stay in your cars. There's been churches that have talked about getting on a radio station and everybody stay in the parking lot to do Sunday service. So what are your thoughts on this and how the public should be going forward over these next several months?
Yeah, those are great questions, Josh, and we get those all of the time, as you can imagine. And really, you know, from my personal perspective and professional and from a recommendation from Johnson County Public Health, it's imperative that for our mental and physical health that we're able to get outside, utilize the parks. I know that the playgrounds and shelters in the parks are closed, campgrounds are closed, but the trails are still open. So I think it's just critically important that people utilize that, get outside, get fresh air, get some sunshine. These are all things that will also help build our immune system, along with plenty of water during the day to keep ourselves hydrated. But we do encourage people to get outside. But at the same time, when you're outside on the trails, and I see this all the time when I'm out running or biking, people are adhering to the 6-foot distance. They are going off of the trail into the grass to when they meet somebody or when they pass somebody. And so I think, you know, I don't know as if there's anybody in the county or the country that has not heard the 6-foot distancing, which is great. It's very consistent messaging. Regarding your second point, and that, you know, I really empathize and understand the need for individuals to be able to, you know, get together for a drive-in or a church service. We've got holidays coming up in April here. You know, the intent is really for that physical distancing, understanding that, yeah, they may be in their cars, that they would be able to keep that distancing, but it's really maybe hard to self-police that. I think that, you know, these are recommendations. They're not mandates, but we just want people to really understand the importance of that distancing, you know, and trying to still get our, you know, social interaction with individuals. It's kind of a fine line and a balance. But again, the intention is just to maintain that distance and only go outside or you know, go to the grocery store or things like that when absolutely needed.
Thank you. I know we've only got time for just a couple more questions. And again, for everyone out there, we will get the rest of these questions answered and post them on our website. But Dave Wilson, just before you go, there's been a tremendous amount of area businesses and organizations. I know you and I have worked with a lot of them to get clamshells and all sorts of things that I'm learning about. I never thought I'd know the science behind clamshell containers, but what is the community's biggest need right now? And what can our community as a whole, how can we better support these 3 absolutely vital hospitals that we have in our community? You're on mute, buddy. There you go.
I think the big things that we run into are face shields, reusable face shields that can be decontaminated. Those are still a need, not only for the hospitals, but long-term care facilities and the jails, the IMCC prison. Those are a huge need. We're still seeing a need for the cloth face masks, like Dr. Shekel mentioned, for those types of folks in the public safety arena that maybe just don't need the heightened level of protection that an N95 or a surgical mask presents, but need them for other duties when they're out and about. We've had a pretty good response from the hand sanitizer community up at Cedar Ridge, but we can always use more hand sanitizer. That kind of ebbs and flows. There's nothing wrong with soap and water, and we still advocate soap and water and bleach and water solutions, but there are times and places where it's not super practical for that. And then the other one is the same with sanitizing wipes and Lysol spray. There are times when those are the only solution that's really functional, where we need sanitizing wipes or Lysol spray. Those are probably the biggest ones. Down the hall right now, they're finishing calibrating our ventilators that were sent over to the hospitals. I know Mercy's already received 9 of those events last week, I believe it was, and we've got another 20 down the hall that they're finishing calibration on. So from things that the community can provide, I would say things like hand sanitizer. People have got 3D printers that can make reusable type face shields. Anybody that can make those reusable, launderable masks would be great. Those are probably the things, along with if your business is shuttered, you're a dermatology office or a dentist office, and you've got personal protective equipment in there that's just collecting dust. Now's the time to pull that stuff and contact us for one of the 3 hospitals, or the paramedics, or the long-term nursing care facilities. Gowns continue to be an issue as well. Gowns that can be re-sterilized, et cetera, are an issue as well. So.
All right, thank you, Dave. I'm going to ask just, yeah, I know you do. I'm going to ask just 2 more questions because they keep coming in, but there's two of them I promised to get to. For Dr. Brennan and Dr. Shekel, one of the questions was, there seems to be articles online about reverse engineering CPAP machines to be used as temporary ventilators for mild cases. Is this something that is being considered for local use?
Yeah, we certainly are looking at BiPAP machines for ventilator use. They don't have all the bells and whistles of a ventilator, but they can be used as a ventilator if appropriately done.
Right. And
go ahead, Dr. Shekel. Anything to add to that?
Part of it is that CPAP machines in their normal use can be problematic because they release more aerosolized particles that are more dangerous. But certainly the potential of converting them into more of a conventional use is great. And, you know, part of our challenge, we're trying to, with the help of what Dave Wilson just mentioned, supplying additional ventilators, we also can convert some of our ventilators that we normally use for surgery, for anesthesia, into something that can help get us through. And so that's true. One of the challenges that we're going to face, and I think other places are going to face, is that things like ventilators are extremely important, but we need the staff to be able to manage those and help manage the patients. So there's potential for a lot of different limitations between staff and equipment.
Thank you. Last question, and then we'll let you go. And really, again, appreciate your time today. This has been very informative, and I'm sure it will be viewed many times over on the website. I want to thank the Iowa City Area Development Group, Iowa City Area Business Partnership, and Downtown District for being our partners in this. The last question relates to mental health. So Judith and Dr. Brendan or Shaun or Dr. Shekel, any guidance you would be provide to as people in the community that are just scared, as you mentioned earlier, to this sort of new normal. And really, in some instances, I know we've talked in the workplace about some of our younger employees that don't have a roommate, you know, and some of this isolation and being used to being out there with their friends. So some of the mental services and advice you would give to those in our community. I'll start with Shaun on that. That's okay.
Yeah, the first thing I would say is clearly most of our time has been preparing for a potential surge. It has not been with treating an abundance of COVID-19 patients. The panic is far worse than the disease right now, and I think those that are suffering from anxiety and in many cases outright panic about the potential that they might contract it the more information we can get to them up front before we talk about mental health resources, which we've invested in and have helped to coordinate. The first step is to remind people that, number one, most people who contract COVID-19 will not be admitted to a hospital, will not need to go to the emergency department. And so it's not the plague. It's very serious for those that have an underlying health concern. It's very serious for those of an older age cohort. But for most individuals, the CDC defines it as a mild respiratory illness. So I think an appropriate fact-based approach would help alleviate a lot of the anxiety and some of the challenges that we've faced around supply chain, staffing availability have been fed by some of the hysteria around this epidemic, this pandemic, and not necessarily based on the facts on the ground. So I think as a starting point, the more we can get facts out there and what it really means if somebody contracts COVID-19, then we can start to address the issues where there is serious underlying concerns that we can try to help them with.
Thank you, Shaun. Judith, Dr. Brennan, anything to add to that?
I would say in terms of, our veteran population, so, the social isolation piece which you mentioned, that, our veteran, are used to being part of a team, a unit. And so that has been, certainly a concern for us. And we have been trying to build additional mental health support for those individuals. But one thing I would mention is if individuals can put into their contact list on their phones, the crisis line number. So that's 1-800-273-8255. And you could press 1 for veterans. Otherwise, it's a crisis line. But I think that's a support that I would like to make sure everyone is aware of and know. And just if you know of veterans in your community, whether they're your family, neighbors, friends, whatever, just to check in with them, make sure they're okay, or let us know, call the hospital as well. If we need to check in with an individual, we're certainly happy to do that. But I think that's important. So thank you.
Thank you. Dr. Brennan, anything to add before we close this up?
I mean, I would just say that mental illness is worsened by helplessness and by lack of socialization. And I think everyone has addressed some of these, but just to be specific about the helplessness, as Shaun said, knowing the facts is really important, but then recognizing that each of us is empowered to decrease the risk of getting this by using all of those techniques that we've talked about repetitively today. The socialization issue, we are blessed to live in an era of technology where everyone has a cell phone, where FaceTime and Skype and Zoom like this can occur. And so reach out to your family members. They're probably suffering a little bit, and a phone call, even go back to, send a card in the mail, right? That's a great thing to reach out and keep in contact with the people that you love.
Well, thank you. I want to just say on behalf of this entire community, we're honored that you're here leading, and just thank you to each one of you, Dr. Shekel, Dr. Brennan, Judith, Shaun, Dave, who's gone now. But I've enjoyed working with you over the years, many of you, and quite a bit, and just really appreciate the leadership and commitment you have to not only your profession, but this community at large. So thank you very much. We will do our best for those out there to get all the rest of the questions answered and provided on the website, icareatogether.com. And we'll also post that phone number that Judith gave as it relates to mental health crisis hotline. So thank you very much, and appreciate all you do.
Thanks, Josh.
Thank you.
Thank you, Josh.